Okay. So will all these conditions present with just up-down tension for 3.5 months?
Sir, Kala Azar could be there, chronic Kala Azar infection could be there. Or
so without any other symptoms?
No, associated with other
Which other
GI
symptoms?
like in case of Kala Azar there could be a gastric nausea.
What else happens in?
No sir, appetite decrease.
So are all those symptoms here in this child?
No.
You asked for history of all that. So there's no history of loss of appetite, there's no history of weight loss, there's no history of fever, there is no history of, you were talking of malaria, so no history of fever, no history of infections. So again, there's no history at all, no other history.
History of fever only since 15 days.
Yeah.
Apart from infection, I would like to jump to other category like malignancy.
Yes.
Could be there because of progressive as well as the fever for 15 days. But as she said, there
Before the fever.
okay.
Then we'll come to the fever and then try and connect the fever. So right now we are at us with apparently no other complaints. Old child. So let me yeah.
Before we go to malignancy, even for us to consider infection, the chief complaint should have been fever.
Exactly, that's what we discussed.
There, we just don't
yeah.
that. And just one more announcement: those of you who are having problem with live streaming, just refresh your browser because there's no problem from this end. It's your connectivity issue which is causing these issues.
So just to put this thing in a proper context, when we said organomegaly, we said which means hepatomegaly because there's abdominal. Thinking of hepatomegaly, how would you group the disease into 4 parts? So which are the anatomical 4 parts? Reticuloendothelial system.
The venous.
Very good. Venous system of the liver. Very good. So now out of these 4, in of a history of 3.5 months of only disease, which do you think is likely?
It could be parenchymal.
So in parenchymal liver disease, what are indicators of parenchymal liver disease?
Any synthetic functions which could be involved.
Like?
Albuminemia causing
So,
generalized distension.
or fluid in the abdomen or edema. So we this doesn't excretory functions.
Like so icterus manifestation.
Okay, which is not yet there. Then
bleeding from any side.
Bleeding from any site would be a manifestation of synthetic dysfunction. Okay. What else?
And then any sensorium and all, there is no history, so excretory function like
okay, altered sensorium will be in a end stage. Can you tell me what is the symptom of acute hepatocyte disease? Jaundice, right? Acute hepatocyte disease, anorexia, loss of appetite, and chronic hepatocyte disease is when it gets decompensated, ascites, other growth failure. Okay, so these don't seem to be there here if our history is correct. So that means disease is less likely. Venous system disease,
it presents with sudden onset or acute onset of abdominal distension.
so abdominal distension due to and with maybe or no edema.
With no edema, with it presents with edema usually.
No, so depends. This means if you are talking Chiari prototype, then you will get ascites and hepatomegaly. Okay. Then third category we say biliary tract. Biliary tract must have jaundice. So if we analyze this till 3.5 months, and if our history is correct, then this seems to be asymptomatic hepatosplenomegaly without any other symptoms. So you come to reticuloendothelial system and then to all these categories which cause involvement of reticuloendothelial system, like hematological you said infection, then malignancy, and then we discussed the pros and cons for all those reticuloendothelial involvement. Okay. Now this child has come with last 15 days fever and icterus. So now we want some details of the fever and of the icterus, and then let's see where we stand.
Fever was of moderate to high grade in nature, intermittent type, associated with chills or icers, responding temporarily to oral medications. And the child was active in the interfebrile period.
Off and on you said, or intermittent means, but 15 days, so each day?
Not each day, no, with intervening of 2 days in between, as the father has told. Like reduced on medication, recover again after 1 or 2 days.
So that means this in 15 days maybe this child has got 5 or 7 episodes of fever. So what do you make out of that? High grade or moderate?
Moderate to high grade. He said he has measured the father 102 degree Fahrenheit.
So what do you 5 to 7 episodes of fever in 15 days, really high, interfebrile, playful, normal. So just general thoughts. Can it be a viral infection? Can it be a bacterial infection? An infection at all? Can it be a parasitic infection? He was talking of malignancy. So is it a leukemia with a fever coming up now? Initially hepatosplenomegaly. Any thoughts on that? Come on, let's just start guessing or thinking, not guessing, thinking logically. We have discussed fever so many times.
Am I allowed to answer?
You tell us. What do you think of this fever?
Could be viral illness.
Okay. Why do you say so?
Because it was, first of all, on and off. Then the child was active in the interfebrile period. Bacterial, there was not like a sick child.
Okay. So what you are saying?
I think at this point of time, let's not forget that we have a hepatosplenomegaly. Now you relate the fever only to that. Starts causing fever at the end of 3.5 months. So don't discuss causes of fever. Discuss the probable cause of fever in a child who has had 3.5 months of an urcid spleen, or both, or one. So you discuss that could it be only liver and now he gets fever? What must that be? Could it be only spleen and now he gets fever? Or could it be both and now he gets fever? So think about how you connect, and if you cannot connect, then accept that it is unrelated condition. Call it unrelated, you must try to relate it. So we will start thinking, could it be only spleen and now he gets fever? Could it be only liver and now he gets fever? You get my point? That, I think, is the problem in this child. So keep all possibilities open to miss a low-grade fever. So first I want to know that at 3.5 months of asymptomatic, you said, abdominal distension, has he been doing very well during these 3.5 months, or he is already getting sick? If he is already getting sick, then it's not a silent liver and spleen. It's already causing trouble. That's most important. But if you say another kilo in this last 3.5 months, I would know whether that kilo came from a liver and spleen. So that only gain in weight also is not my issue. How happy he was, how playful he was, how well eating he was. And if you convince me that he was a normal child, then I would say it could be a coincidental, unrelated. But if he was never all right, then I take him as a sick from beginning, a sickness heightened at the end of 3.5 months. And that's where you start saying, oh, he has got fever now. You get this point? So let somebody start thinking, wildly thinking. The whole idea of our clinic is to make you think. Okay, the rest is we will read. But many have a knowledge who don't think, and therefore they can't put it. So we are trying to make us think. So who will take this? Start with anything. Okay, you want to say he was... So do you know whether he was sick or not sick during 3.5 months? So we need to ask all this. Okay, if you have not asked, doesn't matter. You have learned that you could have asked. That's okay. Okay. Which is the most important part? What have we said every time? Origin, duration, progress. Progress. Not progress of abdominal distension only. Progress of his health. Is he doing well or is not doing well? Yeah.
So she has asked and the child is not sick.
Child is?
Sick in 3.5 months.
So I need to be very sure. If you say child was not sick, may not mean good. Okay. So I want to know whether he was as good as he was before. Now these things need to be asked up front. Okay. Then I would say it was an unrelated fever. Because nothing that most of the diseases start with fever. Why is he getting fever now? So that's not right. So I think you should look at that, right?
Okay. Jaundice.
The parents have noticed yellowish disease and passing dark colored urine since the past 15 days.
Okay.
Not associated with clay colored stools or any itching.
Okay. So, this jaundice, are some more questions important there? Sir said we have to take it as a child with hepatosplenomegaly or hepatomegaly, whatever, presumed, who now gets jaundice. If we are towing the line that this child was otherwise absolutely fine, when he gets jaundice now, then it's little bit of a surprise, and therefore it's an unrelated thing, as sir said. So what questions, and if it, then what questions?
That whether it was of mild grade from the intensity has been increased over 15 days.
Okay, but that though he told you that there was no here. What else?
Don't you want to know an indirect bilirubin by history?
Yes.
First,
She's
pick
saying,
up that.
sir, she's saying high colored urine.
Yeah. So that you are sure of.
Yes.
So it is a direct bilirubin. All right.
What I ask is, are there any prodromal symptoms or anything like nausea, vomiting, loss of appetite?
Really, earlier decrease which has come back to normal. That is increased. Okay. But if you really say now he has a voracious eating, like a child on steroid therapy has an increased appetite. Is that kind of an increased appetite? He is eating a little now. Earlier she was not eating, so it's increased. Increase is a relative term. So make sure. But is there any disease that has increased appetite? But that's a funny statement, increased appetite.
Problem like thyroid, hypothyroidism has increased appetite.
Any other endocrine problem that has?
Cushing syndrome.
Okay, Cushing's. Then any other endocrine?
Functional disorders may also have an increased appetite.
Functional disorders.
What about diabetes? Polyuria, polydipsia, polyuria. Carbohydrate. Those who don't carbohydrates, really wanting to have more. If you have carbohydrates, and therefore a low is because of very high protein that you suppress your appetite. Normal protein, low carbohydrates, or you're craving for it. Carbohydrate dip. Whereas here you take lot of proteins and lot of fat, low carb, that you lose weight. So there are two things. Low carb is a purposeful, imbalanced diet, whereas a carbohydrate deprivation is really normal protein, normal fat, and much less carbohydrate. They want more and more. Rajesh.
Then of one hypothesis, will you entertain that? A viral fever like Epstein-Barr virus causing hepatosplenomegaly, followed by neutropenia because of hypersplenism causing bacterial infection.
Yeah.
I know it's a long story, but if you could
So first of all, the Epstein-Barr which starts, it has to start with fever and not with just hepatosplenomegaly. Then hypersplenism, when it leads to any cell line depletion, usually clinical functional effects of those cell line depletion are not seen, be it neutropenia or thrombocytopenia. Occasionally a hemolytic anemia which gets into hypersplenism may show anemia which is aggravated, but otherwise not. And therefore, getting a bacteria due to that neutropenia is out.
And an EB virus disease has a hepatomegaly because of hepatitis. It is not without
Reticular endothelial
So
enlargement.
EB virus is hepatitis. So
a 4-year-old getting infectious mononucleosis in our country, it's unlikely.
Yes.
It's not a very common thought to go entertain.
Yes.
Why is it not Wilson? Somebody asked.
Yeah, so we are still debating whether it is primarily a hepatocyte liver disease to begin with. Now, if we entertain a hepatocyte liver disease as one possibility, then the various possibilities will come in, and then we will keep Wilson's also as a possibility.
Absolutely. So right now we are just analyzing the story, and somebody wants to know, has someone the distension of abdomen? No, this is on the history.
On the history, yeah.
So we are still talking on based on the story that we have.
Yeah.
how old is the child?
4-year-old.
So Wilson's started few months ago. Little unusual.
And one more question. Who noticed the jaundice? The doctor or the patient? Parents.
So, if you were to analyze, apparently it is conjugated hyperbilirubinemia. Now, if it is conjugated, then we were entertaining a thought of lytic anemia when we were discussing hepatosplenomegaly. Now, for that, getting a conjugated bilirubin is likely, or is it possible? Do hemolytics get conjugated hyperbilirubinemia?
It could be in a late stage where any gallstones could obstruct
Yeah.
the gallbladder.
So theoretically gallstones causing obstruction, but actually we see that in practice, that we see so many hemolytics, but none of them come with gallstone obstruction and obstructive jaundice, right? So therefore unlikely. And our history so far, this child has been fine. For example, you said you increased appetite. We don't get any sign of hepatocyte disease. So then also explaining the coming up of jaundice now on that hepatocyte affected now. If the hepatocyte disease all along, now jaundice as part of that hepatocyte disease, then what else would you have expected now?
Ascites.
Very good. So that a jaundice would have meant a decompensation of the liver. Distension should have markedly increased recently, because it would have led to ascites and edema and all that.
It could be that during this 3.5 months he got some medication. Now that medication is from and down the line now he comes with jaundice, drug-induced jaundice. So give us a drug history as well. Okay. Rare to have such a thing come up, right? For all that we said it may be TB, etc. Somebody must have started anti-TB treatment. So are you done for 3.5 months in terms of
Sir,
medication?
I think she said Ayurvedic treatment only this or all along?
All along, before, at the beginning of February, since then they were...
So we won't know whether their medications cause jaundice because they cure jaundice. So I don't know whether it's also that. So we'll not discuss those, but keep drugs in mind. Somebody
Asked googly. Apparently the father had many episodes of yearly jaundice. So what are your guesses on that? Or thoughts on that?
Sorry, I didn't miss the history. Every year he gets jaundice.
He's giving history of recurrent jaundice, like at least 1 year.
And how much is his alcohol intake?
He's alcoholic, that's what I asked, but history of jaundice since when years of age. And
Started early.
He consumes alcohol. So.
Can it be hereditary spherocytosis in father?
So, is the father having hereditary spherocytosis, and that's why he gets recurrent jaundice? So, your take on that? It's possible that it's more than notice uses or something like that. It's possible, but I would have asked what is the father's health over this time, means whether he's in general keeping good health downhill. That's one important question to decide what category this jaundice fits into, recurrent. And then of course other symptoms like is it conjugated or non-conjugated. He passes high colored urine when he gets the jaundice, whether there are any other symptoms associated with that.
There's no history of passing high, but about the health.
This is probably. So
has the father ever received a transfusion is the question.
No history of PRC transfusion in families.
I think if I look at the hemolytic jaundice and the father looks unlikely, because why every year? Okay. There is no reason why the jaundice fluctuates in a hemolytic jaundice. I really don't know what we mean by recurrent jaundice. The only offside thought was whether he is a G6PD and somebody is giving him cotrimoxazole, sulfur, okay, without knowing. So we want to know how symptomatic that jaundice is. Any hemolytic jaundice is an hemolytic jaundice. By that we mean he is not suffering. Any hepatocyte point of time sure about what's happening with the father, probably doubt what it must have been. The only best judge is he must be having jaundice all the time, sometimes complained of, sometimes notice more. Imagine now if he tells a year I get some illness, I go to my doctor, he says you have jaundice. After so next year he says you have jaundice again. So I suppose he has a jaundice all the time, but only notice once a year. Okay, but I don't think that is making us wiser in terms of. Yes, I suppose so. Though we will start believing everyone. Don't you believe? Yes. So I suppose we will give benefits, take out what best it can. Yeah.
How deep was the father's jaundice?
Sorry, noticed periodically and recurrent. So that's a possibility.
So someone wants us to check the, but I think first we should check the baby's.
Yeah, first we'll narrow potential on the baby, confirm if we think of HS.
Yes.
So anything more on history or we'll examine the child? The child? बच्चे को लेके.
I think this exercise tells us what all questions in the history we must be asking. Okay, we have discussed so many things. Okay, the history should be that in details, and I think we are just learning how good the history can be to make a final. When you start thinking, you know, oh, I could have asked that as well. So that is what it is. Let's see how it is.
इसके मतलब काबिल मतलब मालूम पड़ता है कि आयुर्वेदिक से होता है. पहला ही मुझे मालूम था कि आयुर्वेदिक होता है. वो तब मैं जब अपना एक काम करता था, मैं फील्ड जॉब में मैं मतलब बड़ा पाव ये खा लिया तो उससे भी होता है ना. मेरे आप बात कर रहे थे फादर हर साल होता है मतलब हर साल होता है. ये तो मैं अभी जरा जान चुका हूँ कि काबिल सालों की एक बार हुआ तो बाद में होता नहीं. अभी मेरे को मालूम है.
नाही, आम्ही काय डिस्कस करतोय असले कुठले होतो का तेच आम्ही डिस्कस करतोय. आम्ही तुम्ही जे म्हणताय
तेच त्यांना बोललो माझं पण रक्त टेस्ट करा म्हणजे मला कशामुळे ते काय होतं
करूया.
मला पण थोडं
हो 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 तुमचं ते दोघं करूया ना. आम्ही काय शंका नाही करत की तुम्हाला नाही. आम्ही विचार करतो कुठला रोग असेल ज्याच्यात तुम्हालाही कावीळ असते आणि बाळालाही असते.
तुम्हाला माहिती
तेच नाही नाही करून तुमचं. एनीबडी वुड लाईक टू एक्झामिन? कम क्विक, कम ऑन, व्हॉलंटियर्स. Good, very good. One person.
Icterus is present. There is abdominal distension that is present.
So what is the interpretation you observed in general from how to the discussion that we were having on history?
So since we were suspecting disorder or a malignancy or any other disorder in the kid, a malignancy would usually have a cachectic child. Infection would have, which the kid is not. The kid is icteric. It could be hemolytic, and hemolytic faces. It's not very.
एकदा पोट बघूया. हां, अच्छा अच्छा. Inspection.
So the abdomen looks distended and equally distended. Local bulge as such seen. Umbilicus is central, not stretched. There are no scars or sinuses present. There are no dilated veins seen.
If I ask you just by look at abdomen, tell me whether to fluid or other reasons. How will you tell me? How will you tell whether this distension is due to fluid or no?
Flank fullness usually suggests and transversely stretched umbilicus.
Excellent. And both of that are not there. Anything else?
So dilated.
Anything? What?
Some organomegaly.
In the upper abdomen. So therefore, meanwhile you tell us on general examination any other tell us the height, weight.
Height is 88 centimeters, which height comes under less than -3 standard deviation. Weight is 14 kg, which is between -1 standard deviation and median. Weight for height.
4-year-old child. Normal or less?
Less.
88 is for what age? 2 years. And weight is 14 kg. For 3-year-old diseases, height is only affected and weight is not affected.
The weight, normal weight could be a pseudo or false sign in such a case. Weight in such a child could be a pseudo or false sign.
Okay, so she is suggesting that the weight may be misleading. There is no fluid. If at all, there is just organomegaly. So your 88 is correct? Are you sure of your 88?
No, I am not very sure. Okay, it can't be 88. If somebody has a thing, because 88 will mean a short stature and we'll discuss something totally different. Okay, to look at it looks bigger than 88 to me.
No, and so first of all, we just by our eyes we question the 88.
Yeah, we are not questioning the tape. Our eyes can't be as good, but still there is a suspicion.
But okay, if at all it is that 88 and the weight is good, then one is, as they said, look at any wrong reason misleading for weight like edema, which is not there, in which case that height has to be constitutional. It cannot be due to a systemic disease.
So there is no tenderness. Liver is palpable, 7 centimeters from the line. It is soft, rounded margins, The left lobe is palpable. It has a span of 12 centimeters. The spleen is also palpable, 3 centimeters from the costal margin along its long axis. There is no free fluid that is appreciated.
Any other positive on the abdomen?
No, sir.
So tell us, what is your...
What, pallor, you said? Is the child very pale?
The child was pale, and at the time of admission, the child has received one PRC transfusion.
Okay, so now after examination, what are your thought processes? And so what are our positive findings? We have a normal growth,
No.
and we have icterus, and we have hepatosplenomegaly. That's it, right? And pallor, you said on admission, which a PRC transfusion has been given. So now what are your thoughts?
So could be.
So go systematically, don't just final diagnosis. Analyze, to describe the whole process. Use 3-4 sentences to use adjectives to describe the situation.
4 years old female child with hepatosplenomegaly, with icterus, without ascites or no signs of liver cell failure, with anemia, could be suggestive of some hemolytic, with normal growth.
Okay, so kind of hemolytic, congenital or acquired?
It could be an acquired hemolytic.
Like?
It could be autoimmune.
Okay. So autoimmune hemolytic anemia. What else? Why not congenital? So again here that height reading is extremely important. Height reading is really short, then it's a different issue, and if it is not, then it's a different issue. Okay, any other thoughts?
Since the father has been complaining of jaundice as well, and the kid gives history of 4 months of, it could have been that the organomegaly was present from before and has married 4 months, and with icterus, with anemia that required transfusion. So it could be most likely a congenital disorder that has manifested now.
But congenital disorders we discussed, no, either they manifest very early. They don't kind of wait till 4 years to manifest, no?
If the father is a sickle trait and the kid is also turns out to be a sickle trait with some infection causing anemia.
Sickle trait is causing disease, jaundice in the father repeatedly.
Could cause.
Why should sickle trait?
Not manifest as an abdominal distension itself.
Anybody else? Any other?
Storage disorder.
Very good. So storage disorder. Which storage disorder?
Glycogen.
This is a spinner. I can't explain that just now. But if we think of it as a reticular involvement, hemolytic, one of the should be discussed as a storage. Is it a consanguineous?
Non-consanguineous.
Non-consanguineous. Sir?
I think all that I can say is the liver disease. And the reason is that liver is not pathological. This liver is soft to firm, not much enlarged. So this...
So liver is firm actually. She said soft and it's enlarged.
What attracted my attention, liver and spleen are not so large, but the abdominal distension is out of proportion. I thought from a distance that there will be a large liver and spleen to look at. Abdomen looked very distended, but the liver and spleen is not that big. You will not find so much of distension. That may be a possibility. But this liver is not so large, the spleen is not so large. Even then, the abdomen looked very, very long, much distended. We know that this child had a severe pallor, which required a transfusion. There is no doubt that this is a hematological disease. We will have to explain a hematological disease because there is no liver disease. This child has done well in weight. If the length is correct, then short stature indicates a chronic hemolytic anemia. So, clue that yes, child of anemia has a short stature, and this child is a short stature. Say then he has a chronic hemolytic anemia. The question is, why is he having jaundice now? So that I think remains unexplained. And like the father, we don't know why every having jaundice. So yes, we have some issues which are not. And I think that's where probably some depth in the history could have given us some clue. Not necessarily, he may not know enough. But one thing is sure, looking at her, two things are prominent. Abdominal distension out of proportion to liver and spleen. And the second is, if your measurements are right, then that's a chronic hemolytic anemia. But by then, she faces too. And to that extent, it's a chronic progressive hemolytic, not like hemolytic anemia. So, this tells us that when you get a story of a high color, you need to be sure what does high color means to the parent. You must ask, is it deep? Then you will say, no, I think it's a little yellow. So what is high colored is all right. What is high colored in your mind is the direct bilirubin. Any colored is a high color. What is low color? Or what we are dealing with. If you got a transfusion, then it's a hemolytic disease. But do you have a liver disease and a hemolytic disease? There, Wilson's is one where it's common. Wilson's can have a hemolysis and Wilson can have a liver disease. Tell us what investigations have been done.
So this child was developmentally normal?
Yeah.
Developmentally.
See, when you talk about the storage to develop jaundice is a late phenomenon. If this storage is just 4 months old, yes, without jaundice, very much. But storage to develop jaundice would have taken a long time, and therefore that probably is unlikely.
So there is a... Sorry.
You finally say that few things are unrelated. We are discussing everything under one umbrella. That's where we are getting stuck.
There is one comment, and he says that what goes against chronic hemolytic anemia is the normal growth, but we are talking about short stature, so she's not growing normal. Absence of hemolytic facies. Now the hemolytic facies will depend on the degree of hemolysis that is going on, and it need not be present floridly like you would see in a thal major. Not against, but we'll have to find out. It's an unusual type of hemolytic possibly.
So complete blood count, HB of 5.8 gram per deciliter, count of 19,200, platelets of 7,49,000 with 2.6%.
Yeah, so one sec. So how all this quickly?
It's a microcytic hypochromic anemia with wide RDW.
RDW suggests what?
Anisopoikilocytosis. The variation.
Nutrition.
No, so
Normally, hypochromic microcytic with a wide RDW goes most likely in favor of iron deficiency, and hypochromic microcytic with normal RDW in thal trait.
So, and what happens in thal major?
It will be very wide.
So it will be extremely high RDW. So again, so what I mean is, when you say high, you have to specify high or very high, because here we are discussing a hemolytic anemia, we are discussing a thalassemia type of a picture. So this 55 is high or very high?
High. High.
High. So it just suggests deficiency anemia.
Would thal on this?
No, sir.
Okay, go on.
Why are the platelets high?
Exactly, why the platelets?
In case of iron deficiency anemia, because there is microcytic 6, direct 2.6 total bilirubin, direct bilirubin. Enzymes of AST and ALT 128, ALT is 1, alkyl hyperbilirubinemia.
Only a little small rider here is that smaller the bilirubin, it's a easy investigation to do in a lab. There could be an easy error. Smaller the bilirubin, there could be a little error. By logic, yes, it's direct. But we'll certainly keep our minds open, because bilirubin is not so easy investigation, direct, indirect.
There is mild elevation of the enzymes. So
Which is more involved?
ALT, SGOT.
What does that mean? More than SGPT, right?
No, ALT.
ALT.
So PT is more involved.
ALT is more?
Huh.
Okay. Alright. So what does
Injury.
So there is a hepatocyte involvement probably, yes. Alright.
Total protein of 6.9 and 0.5.
An albumin of 3.5.
28 milligram per cent.
On the hemoglobin CBC, you nucleated cells on peripheral smear?
No nucleated cells. Thalassemia, sir.
Okay.
MCV upon RB.
What is a corrected retic in this child?
Alkaline phosphatase. And what else?
USG active of hepatomegaly with texture, with coarse texture, megaly, mild periportal.
Portal, etc. They have not said.
No, sir.
So after the investigations, what is your analysis?
It might go into.
Does the urine routine show?
No, sir. Urine and urine bile salts, bile pigments are also absent.
So urine bile pigments absent means what?
In case of infective hepatitis, we usually have this bile salts, bile pigments positive.
So more than hepatitis, as sir said, we are seeing whether this bilirubin is indirect or direct. Now, direct, then urine must have bile pigments. Absence of bile salt, bile pigment favors. What is odd is the migration of the liver enzymes, right?
And Rajesh, if you are thinking of him, you should have a high retic count, which is normal. So again, hemolytic seems to be because of that. This is unrelated.
So any thought?
I think for a simple iron deficiency, there is no reason why somebody has to give a transfusion. Okay, this child at 5.5 chronic iron did not need a transfusion. This child was not in cardiac failure, I suppose. And so there is no reason why somebody has given a transfusion in an iron deficiency. So that's my impression. Second is, there is a significant liver and spleen. You don't iron deficiency, so that part is out. Is it a significant? To my mind, probably not so. Well, there is some evidence of some liver disease. It has happened now, because the story runs after 3.5 months, fever and jaundice. Said, are these two unrelated issues? Still, findings may suggest an acute liver disease. And an acute liver disease may be any other virus. I'm just imagining now. Suppose there is some transmission of B, C, etc. Was it totally a malaria doing that? Okay, this child had some fever, he has an iron deficiency anemia. So malaria can explain liver and spleen. But the story is that it's going on for a long time. Again, as I pointed out, that to me abdominal distension is out of proportion to that liver and spleen. So I'm a little concerned why that is so. So is this child having totally something else? So I think at this point of time, we have no clarity at all we are doing, and I'm sure you are also not sure what this child has ultimately, and therefore except a transfusion you don't know what next to do, and I hope you have not done anything else at all, because you don't know what to do. Yes, so looks like you at the end of the whole investigation, and we here after discussion are still not very clear.
There is a question, can it not be non-cirrhotic portal fibrosis?
No, that is a congenital hepatic fibrosis, and that congenital hepatic fibrosis really comes as an extrahepatic, that is pre-sinusoidal intrahepatic portal hypertension. Okay, the liver is very firm. Jaundice is not a feature unless a liver starts failing temporarily. Child is often, therefore this is very unlikely. So, but a good suggestion. What the person who asked me, father also?
Not yet.
No, I think get on. Well, he is also concerned about what is his problem.
One or two small comments. First of all, I wonder when we will get your sir. No, sir. Sir. Because when he told me 2 things, he told me that the appetite is very good. And I was racking my brains that I didn't get to take a full list. 3-4 things. That appetite is too good. He actually told that. And the fact that the distension reduces. So which means that the element of other distension. And therefore, because we are stuck, I am saying that, whether this is an unrelated illness. Means suppose this is like a hepatitis, which is getting better almost. Then we will have to define that, because sir said that good means after bad appetite. And we all know that hepatitis, when they recover, they start eating very well. So whether you can mark that period behind, 15 days behind, that's why I was asking you whether the stuck at, how to explain.
Last thing, somebody said about this, we discussed this.
Months, which is, so we have discussed that this is A, we are still not convinced on examination at least that there is hepatocyte involvement. So that's why we are not entertaining Wilson's. A Wilson's getting autoimmune hemolytic anemia and presenting as anemia as well, that is in a far advanced Wilson's, where the original diagnosis of Wilson's will not be in and that suspect Wilson's in any kind of presentation. So suspect it asymptomatic hepatic because it's a treatable. Logical reasons why it seems less likely.
Okay, there's another comment, and which I would like to respond to. He says, which cirrhosis or fibrosis hepatomegaly? In the pediatric age group, cirrhosis comes with hepatomegaly. It's the adults who have shrunken liver. So we feel a hard, firm liver in a child with cirrhosis, and the hepatomegaly which Sir was referring to was extraportal hypertension intrahepatic. That's known as simple hepatic fibrosis. Pediatric age group, it's very unusual to get cirrhosis without hepatomegaly. Sir, would you like to add?
I think so. No, I think now what is clear, he was holding some important findings with him. Yeah, he was trying to rack our brains too. I think now it's clear that he is a reasonably healthy child who has an iron deficiency. Now he has an abdominal distension which could be gaseous. We don't know why it developed months ago, and I think it could be related to constipation, related to any such factor. And in that, this whole story of liver disease is where it starts with fever and mild jaundice. That looks like a high-colored jaundice. That's a hepatitis. So it's a hepatitis. Okay. In a non-child with iron deficiency, with a gaseous abdominal distension, which could be constipation, there's no reason why she should get gaseous abdominal distension. Gaseous abdominal distension is an intestinal, and therefore a chronic diarrhea. Children have abdominal distension. Otherwise, probably constipation. And constipation is not ask one question, how often do you go to school, various things that. So now I think to construct the whole story, it's looked like an acute hepatitis in a child who has got a chronic iron deficiency anemia and a gaseous distension of abdomen. How we can totally be misled totally into that.
But a firm liver also
soft to firm, everybody said. And what is firm? Any space occupying lesion in the liver. After all, the hepatitis, the liver is hepatocytes. So there is a firmness. Wait for a while, this liver becomes soft. Okay, this is well, so already the liver is getting better. So if we follow, and therefore this is not viral A and viral A. What it is then. So again you go back, malaria, typhoid, leptospira, etc. Typhoid, leptospira is out, stands to be there. And if primary hepatotropic is it, so I do that, yeah? Fine. Okay. If I have nothing else, I would say all iron deficiency are without liver and spleen. There could be. Once we know the diagnosis, likely you fit in those typical, push it in.
And see the point, take away the liver, then now that hereditary spherocytosis also comes in. We'll have to look at
cytosis. You must ask the examiner, can I examine father or mother?
Which have come in. One was whether right-sided failure could present like this. Well, he will not come with abdominal distension, he will come with breathlessness and such other have to have.
Correct.
I think we'll stop the case here, sir.
I think
Thank
so.
you, Dr. Anita. And our next case is going to be presented by Dr. Pallavi. Dr. Pallavi, this way.
My patient is 22 months old. Hailing from Chennai, an informant being mother. Chief complaints of fever since 3 days, cough and cold since 2 days. Patient was apparent, then she started having fever, which was mild to moderate grade, gradually rising, intermittent and not associated with rigorous rash, cold, which was initially in the form of low nose and then having nose, and simultaneously had cough, which was dry, cough, intermittent, and not obvious admission in the past. 2 months child gets sick, that child gets cough and cold. Birth history she registered till booster. She speaks full sentences with meanings and can communicate with parents and other. She can dress and appropriate for the age. Family history 5.
Can you just repeat that diet thing? Speak properly.
Her requirement is 1100 kilocalorie per day and proteins are 11 gram per day. But 800 kilocalorie in 8 gram, which is deficit in 300 kilocalorie in caloric and proteins 3 grams deficit in. There are 5 members in the family. Husband, watchman, year-old. Second one is 3-year-old and this is 22 months.
Fever, cold, cough for 3 days and not growing well.
Yeah.
That's
not gaining weight.
Not gaining weight. If complaint.
Weight. She has come basically for only cough, cold and fever.
So why admit a child of fever, cough, cold for 3 days? When you say that the fever is not,
She was breathless. It could be viral infection in a.
anybody else? Anybody else? Analysis of this fever, cough, cold?
So just acute respiratory infection, and as she has mentioned the history of cold every 2 months, so maybe hyperreactive airway disease with viral infection, became breathless and needed the admission.
So what more details do you want of the previous episodes?
No, there is no
Organization as a pointer, wheezing or whatever. Okay. So your analysis is perfect. That just now it sounds viral infection, fever, cough, breathlessness, and
Was child breathless? Was child breathless every time she had fever and fever, cough and cold?
Yeah, mother is telling that child gets there is a increased rate of breathing and difficulty in breathing. That's what mother said.
episodes or
But
most of the past episodes.
Most of the, but
activity.
yes.
She assumed fever. Very good. So was there fever in all the episodes or most of?
Abdominal cough, how long it persists with fever or without fever, and needs nebulization for the relief of cough or breathlessness.
And what started fever or?
Very good. So what started whether fever was significant of each time. Basically what you are trying to do in your mind is you are trying to divide whether these are infections repeatedly or whether hyperreactive disease, which may also mild fever, and an occasional episode is triggered by a viral infection. Situations are different and you can analyze them based on your history. So which one is here? Hyperreactive respiratory activity every time. There is coughing every time. Cough is a dominant symptom.
Fever was mild to moderate grade.
In the previous episodes. Starts with fever or starts with cough and cold? Starts with fever.
For the illness.
Okay. One reason, but back.
Breathless followed by.
We have fever to begin with, which means infection. Then we'll have to really decide whether or lower risk. So did you take the history of?
So somebody said,
why is this not a high?
There is no history of feeding difficulties or success. Every time heart is getting decompensated and settling down without any medication or any admission till date. And there is no visible.
And if a child was such that would get decompensated. What do you think of that weight?
Triple.
So again under 1 year.
Just under 1.
So all the 3 parameters seem to be fairly parallel or constant. So don't just go by one absolute reading and say, less than this, less than that. You have to correlate all 3 and seem to be correlate to the same, so to say. Okay? Okay. This has to be always correlated with clinical signs of malnutrition. So do you think she has clinical signs of wasting? Look at the mother's height. Yeah? like a happy child or a sick child?
Happy child.
So correlate everything. So don't just go by a number and say that 7.8, so minus less than minus 3 standard deviations. That doesn't mean anything. Okay, go on.
Child is conscious. Child is conscious and in right radial artery with good volume rhythm. Respiratory rate is 40 per minute. Blood pressure is 98/60 in right brachial artery in supine position. Anterior fontanelle is closed. Depressed nasal bridge. Eye ear appears to be normal. Oral cavity, there are 26 teeth. There is no carrier teeth. There is a rickety present. There is a widening of wrist.
Malleoli, etc. सॉरी, आप एक काम करो, आप ये रख दो इधर, इसको गोद में और इधर आके खड़े हो जाओ, इधर आ जाओ. To palpate and थोड़ा सा ये पाँव ऐसे, आप ऐसा ये हाथ में ले लो. If the camera can focus on this, this is definitely double malleoli that can be seen better. What else?
Systemic examination. Systemic examination on RS bilaterally equal on serious
Of LRT, don't use so many abbreviations. We don't understand.
Yeah.
So first tell me why LRT. So do display only which part?
Alveolar.
Very important. If you are getting signs bilaterally and over, then it cannot be parallel because you can't have a parenchymal bilateral all over. Correct? So what is all over?
Saying to that.
Yeah. What is all over is airway or interstitial. This being a short history of 3 days only, it's unlike interstitium, or this is an airway. Okay, so this is, as we were discussing on history, a viral infection in a child which is a generalized of the respiratory system, primarily affects the airway. This we already said, it's a hyperreactive airway because of the past history, right? Okay.
And Rajesh, a viral infection cause acute interstitial issues,
Yeah.
which will explain your crepitations. Airway disease, you would expect either rhonchi or something, so that's how it fits in.
Between minus standard deviation, and mid-arm circumference is also 12 centimeter.
Yeah, so that is where I was trying to tell you that you need to correlate everything in then the height age, which should be the height. Okay, this should be the pattern of malnutrition, and always relate it with clinical signs of malnutrition. So the child should look wasted, the child malnutrition, the child should be irritable or whatever, and there should be other signs. So as we discussed here, feel that the 3 parameters are of the same age. 73 centimeters, 7. G for a child who was born 2. And head circumference 44, right? Now where is, what more will you interpret in this? In malnutrition, is head affected? Head is spared. How old is this child?
22 months.
What I am trying to say is that whenever you are calling somebody as based on a single value, translate all three before labeling as malnutrition. Now, part was what? Ma'am with what?
Signs of rickets.
Yeah. Plain rickets, malnourished child if this is malnourished, and otherwise side that this is not a malnourished. Yeah.
So blood pressure she's by 60, which sounds a little on the higher side.
Yeah. So 98 by 60 on the higher side. So how do you explain that?
Crying.
Crying child. Simple. Pass it off on the crying child.
Renal issue, sir. Rickets.
Yeah.
No, I think Amol has got a point there. He would not just pass it off on a crying child with this story.
Renal story, having rickets, not gaining weight, hypertension.
There is no history of chronic in the baby.
We can't hear you.
There is no history. There is no any history of chronic medical illness in the baby. Like got
No,
admitted for that.
Did not get admitted, but what they are trying to say is that this baby is failed to grow because of renal issue. So that's why it has rickets, and that's why this baby is giving you signs of early hypertension. So how do you counter that?
Does a child of renal rickets
Renal rickets is tubular.
of problem in the renal rickets?
Tubules.
And does tubule cause hypertension? Why are you connecting the two at all? The renal glomerular disease not cause rickets?
Can cause
No.
because
So
there is
how
a
will it cause
conversion
rickets?
of vitamin active liquid.
Severe nephritis, for example, a pyelonephritis, say undiagnosed, poorly treated, okay, could fire off entire kidney as well. And a chronic renal failure occurs that could cause rickets as well. That can have hypertension. But a typical renal rickets is the tubular defect, no? There is no hypertension at all. This child obviously, again a renal rickets child is a failure to thrive, and this is obviously a deficiency ricket, there is no doubt. History is very typical. The child started milestone, but thereafter did not mean that this child vitamin D deficiency, developed rickets, nobody treated, then the milestone started. So this story is very typical of rickets. Okay. So, do you think it's there for hypophosphatemic rickets? Hypophosphatemic rickets, the head is spared. It starts a little later in life, and the story at 1 year normal, thereafter no. So I would say the hypophosphatemic rickets started when the child started putting risks on that. So this child started rickets early. Phosphatemic rickets. It's simply classical vitamin D deficient rickets. But then why had the head issue? So then I want to know whether it's got a small fontanelle close looked a little funny to me. And I said, why is that so? Why should the fontanelle be open in a rickets? Why do you think the fontanelle is open in rickets? Anywhere, no? This is pressure. The leg findings are pressure and the mother skull to say that. And therefore the skull is small. In that small skull, the skull has already grown well. Initially, when there were no rickets, fontanelle remained closed. The rickets progress. So there are many ways of looking at this child. I think this child obviously is a happy child. We already discussed everything about cough, etc. And I think the most important part of the recurrent fever, somebody rightly put up congenital heart disease. What is the major difference? A child who is not doing well, a child who is doing well. If a child is doing well and has repeated cough, it only means that a child is absolutely normal and recover. It's only two conditions. So why are we worried about recurrent? In fact, next time you see a small birth weight child or a preterm child, you need to tell ahead of time that there could be recurrent. But don't get worried. You don't need hospitalization, you don't need much medication, you just need a symptomatic treatment to keep them well. And they're growing well. So this is the story of a transient visa. The next question you could have asked is, how did this start? Transient visa starts very early. A viral infections come a little later. How did he get a viral infection? It's not mixing with. But if he has started wheezing at 3 months, 6 months, etc., then he has a wheezer out of a thing. If that is so, next question is the wheezing getting better? And the transient wheezer starts getting better beyond 1.5 years, and by 2 years, 3 years, he is already normal. So progress of wheezing. So there are so many questions that you need to ask. And examination findings are all common in everything. Examination differentiate one from another, but a good history differentiate. So a transient wheezer, if we don't find a transient wheezer in this child, for example, he was born 3.5 kilos, then I start wondering, why is he wheezing? Does he have a GER? Does he have an aspiration? Does he have a congenital heart? What does he have? That means it's much more pathological. And if that is so, he is not growing well. So growth is so important parameter. And in a small child, how do you pick up a growth? It's difficult to say whether child is growing well. But it's easy for the mother to say if the child is happy. One who is growing well is happy. One is not happy. One who is mal. And I think therefore the diagnosis is simple in this child. Transient wheezer, hopefully getting better, and in a child who has got no failure to thrive, but a small stature, constitutional or genetic. Of course, the low birth weight itself has contributed to it. And on to a vitamin has developed rickets early, but has not progressed further in terms of worsening rickets. If it has started early at say 2 months, 3 months, by now he could have had a florid, but thereafter his growth started slowing down. Initially, the growth must have been better on a breastfeeding. Thereafter, the growth slowed down, continued, but the rickets did not progress. People called it an atrophic.
How will you investigate?
Routine investigation.
Speak in the mic
CBC,
loudly.
Complete hemogram with X.
You could say X-ray any part. But every time you say X-ray wrist.
To assess.
So why X-ray wrist?
Sir, carpal bones are there. So bone age we can determine according to presence of the carpal. And
do you
also,
need to determine to diagnose rickets?
No, and also sign of rickets like splaying.
No, so don't mix up the issue. So first of all, carpal bones will give you bone age, but here you don't need bone age,
Yes.
right? Rickets. So that's separate.
Mm.
Now, sir is the splaying and all those signs can be seen even.
This child is walking, so maybe the signs are not prominent.
Okay. So why do we conventionally take wrist X-ray?
Conventionally, you give a BCG on the left side, right? Yeah, that's it. I just wanted you. Knee is also fine. There's no reason. When you're saying the wrist shows early signs, but not early radiological signs. Wrist shows early, but much before wrist, the costochondral junction. But radiological signs are coming all over equally. Any bone could have been taken, but by convention, yes. So there's no reason. You could have bone if you like.
Why so many X-rays, Rajesh? Why chest also? Why wrist also? Why X-rays? And why are we chemistry before we are doing X-rays?
Support.
Pay for biochemistry free means what's the logic?
So tell us why X-ray chest and whether you want to do any other.
Serum
But
calcium.
suppose chemistry was done and alkaline phosphatase was low. Child has rickets. You did X-ray first, as he said, and then you biochemistry. Alkaline phosphatase is lower. At, say, 6 months of age. I didn't do it at 22 months of age. Do you get that? Any clue? So in which rickets the alkaline is low? That's the question. Hypophosphatasia. It's fatal by the end of 1 year. No, I would have done it. Yeah.
Speak in the mic loudly to demonstrate hyperparathyroidism. Would you like to do vitamin D levels?
Vitamin D. Serum vitamin D levels, what?
Which component?
D3, sir.
20.
I thought 125 is the final product. It's not the final product. 25 OH is just the liver. 125 dihydroxy is the final. Why should I not do that? Why do 25 OH?
25 gives us the stores of vitamin D, the overall.
I don't want to see the store. Okay, should I not product 125, not 25 OH?
What is the
Short
half-life
half-life.
of 120?
Short half-life.
Why you're not going?
25 OH is low, only diagnosis is a vitamin D deficiency. In all other kinds of rickets, vitamin 25 OH is not low. 25 OH low means the diagnosis at all. But 125 OH low, if you want to differentiate deficiency from resistance. Economy is an issue. In this child, I am very sure it's that. And it's so easy. I'll give vitamin D and show the improvement. Radiological, biochemical. I know it's a vitamin D deficiency. I agree with you. If you want to have a final proof, yes, the final proof. You said in the earlier deficiency without doing serum iron. And tuberculosis without AFB. And we call pneumonia without knowing who is causing pneumonia. Fair enough. Because to find the further label of diagnosis, it may cause trouble. So that's the reason. We started first in this child. If respiratory problem started before, then I won't blame it to rickets. And the rickets has to develop and then start recurrent infection. So, egg first or hen first. So, that it does well.
What is the incidence of vitamin D deficiency based on the levels that you do today? Just gross figure. What do you think it is? It is anywhere 80 to 90%.
Yeah.
So whatever disease you have, you do vitamin D levels.
The third one was not checked. So,
Okay, you have any tests on this child? Any X-ray especially?
X-ray, I'm not sure. 3 hours he got admitted. We
Okay.
are sent.
Okay. How will you treat this child?
According to STOS regimen,
25 to 150 milligrams per day. That's calcium.
yes.
But STOS is not popular with any
You can
endocrinologist.
do week for 10 weeks.
Okay.
Once in a week.
Yeah, so that's what you're going to say in your exams, because everyone is not in favor of STOS. And they may also object to need to give IM, and when do you not need to give IM?
Orally not accepted.
You can give it orally, but when do you have to give it IM? When do you?
They are not taking properly. There is
So if
compliance is not better.
If there is malabsorption,
Malabsorption.
that is the situation. You have to give it intramuscular. Can I ask one last? When will you see whether there is a biochemical response? Will you repeat?
Sir, after 15 days, after 2 weeks, you wrist X-ray for see white line calcium.
Any other inputs?
Alkaline phosphatase.
Elevator.
Alkaline phosphatase will normalize by serum calcium 3 weeks and 3 to 4 biological.
Yeah, so radiology is last. The first change will come in alkaline phosphatase, which you can do at 4 weeks to 6 weeks anytime. What's the rush? Okay.
and there is a line. I mean, why specification you first see on 15 days?
It may be given in Nielsen, which does.
Since you are resistant and you are fighting out, decide the two as early as you want. That is what is making how long for all these deformities to get better. Some idea, some guesswork. 1 day, 2 day, 1 month, 1 year, whatever.
So it takes a longer time, years, maybe
It
2 or
takes
3
several-
years.
Okay. And at the end of that, it all clears alkaline phosphatase.
Improving gross motor milestones.
Sir, if a child comes with do we correct it medically first and then go for a surgical intervention, or first do surgical
There's no need for surgeon. Therefore, in a resistant rickets, you will ask him whether cosmetically it's okay for.
Vitamin D. I give vitamin D. Having answered.
No, so vitamin D deficiency.
So what is affected?
Epiphysis.
Take the mic.
Epiphysis or
So
not?
what is the reason for short stature?
And-
Deformities that
Yeah.
cause your short stature. The height is determined genetically in any.
Vertebral lower limbs. Okay, unless the lower.
Spine also, and there's a contribution from the long bone. Okay.
If that is so, then what are the radiological signs? Chondrodystrophies look similar. And rickets look similar. Disorders on an X-ray.
Cupping. So there are 3 words we use: splaying.
What they describe in the text.
Of course, there will be other features of the dysplasias, but what is how these 3? We know how we talk of cough, cold, fever. Ping.
By half an hour, Rajesh. So yeah, it's 8:30. And we must thank all our online viewers for staying online so long. I hope you enjoyed the session. We the announcement next broadcast that will be on Wednesday, the 10th of November, from December, from Chennai, 2:30 p.m. And this will be conducted by Dr. Bala. So you're in for a treat. See you again. Bye.